I don't want to make people that are already online wait forever. So it's truly a pleasure to have introduced today's speaker, Julien Calderaro, who is an associate professor in the Department of Pathology. As you can see from the screen, if you see him, you have the microscope. He has a microscope next to him. And as he just told me, the sections you can still see there, which are archived, but that's soon going to be history. He works at the Henri Mondor University Hospital in Creteil in France. And obviously, he's interested in liver cancer, and that's why we're very happy to have him. He's an expert in liver disease, tumor diagnostics, studying the tumor immune microenvironment, but not only that. And he has been instrumental in refining morphomolecular classification of liver cancer by the WHO. But apart from this, he is also very interested in artificial intelligence-based approaches. And obviously, that's something that we are all very, very interested in. And that's the reason, one of the main reasons, obviously, why he is an invited guest as pretty much any international liver cancer meeting. And he always gives very interesting and sometimes also very provocative talks about this. So I really like this. So without further ado, Julien, why don't you go ahead with your talk? And thank you for speaking to us.
So thank you very much, Tim, and thank you for the invitation. So I think you should see my screen now. It's okay.
Yeah, it's good.
Okay. So I will discuss. I think the main topics, hot topics in the field of application of artificial intelligence in liver pathology. So first, I would like just to introduce that it's not the case for medicine, but you know that now AI is almost everywhere. And for example, this is a supermarket near my home. And now when you put a bag of vegetables, you have this camera here, and they recognize that this is tomato. And for example, you just have some proposition. So you can see here that the model has identified that this type of vegetable should be one of these 4 type of tomato. So basically what they have is an AI model that was trained on images. I can imagine that they give images of different vegetables, and now it recognize automatically the vegetable that you put, and so you don't have to go through the menu and to identify what you want to buy. So you can see here it's rather difficult because tomatoes look alike, and when you give something different like a banana, which is really obvious, and you have only one proposition, and it's directly the good one because it's very easy to identify by the camera. So to implement that, for example, I think they must have trained models to recognize this type of vegetables or fruits, even when they were in bags, for example. And now you have this type of application in a daily life. So we will see that it's not the case in medicine because of course we have to be careful, but it's really I think everywhere in our environment, and there are still some obstacles for the implementation in medicine, and that's this kind of obstacles that I will discuss, and the potential applications. So the first, you have to know that the application of AI in pathology is mainly related and mainly possible to the digital revolution that our specialty is undergoing. So scanners of slides have been around for now almost 20 years, but yet a lot of departments are not digitized, mainly because there are massive costs from the IT part, because for example, in my department, we produce, I think, approximately per day 1,300 slides. And one slide, if you scan it at a high resolution, which is needed for diagnosis, is approximately 2 gigabytes. So what we produce is 2 tera per day of data. And the data has to be available. So quickly, you have to access quickly to the slide. So that's a major, it was an obstacle for the implementation of the digital slides, because you have really to have a very strong IT department to have really to be able to access to the slides in real time and so on. So what does these scanners? They transform these conventional glass slides into what we call a pyramidal image. And this is the format of the digital slides. Because if you want to be able to zoom in and zoom out just like with a microscope, you have to have this kind of format, which is called pyramidal. You have different resolution that are scanned. And when you want to see the slide at an intermediate resolution, you have an interpolation of the pixel and a new image is created. And in fact, the images are stored as a lot of smaller images that now are put together and make the whole slide. So for example, the cost involved in digitalization in a big department is approximately, so in euros, it's approximately 1.5 million euros to go fully digital with the scanners, the server, and so on. And so far, we do not know if it will save money for the hospital. And I think also that was one of the obstacles, because the administration of the hospital, they want to invest when they have a return on investment. So it's still not very clear how much money we will save with that, because we have to produce the slide. So in fact, we had another step in the pathology workflow. We still have to produce the slide. And so in approximately now in France, we are like 30% of labs are digitized. Really, UK and countries from Northern Europe are really leading the way. They are like 60 and 70% of labs that are digitized. So just some short reminders on what is an image to understand why we can apply AI. So an image of histology, but also whatever image, the pictures that you take even with your phone, is a matrix of numbers. So each pixel has an X and Y localization and X and Y coordinates, and a value, which means the intensity in gray levels. The particularity of pathology is that, in fact, the image that we have is in color compared, for example, for MRI or CT scans. And the image is, in fact, the addition of 3 different matrices. One is in red, one is in green, and one is in blue. It's really the most frequent way to encode color images. So what do we do when we want to train AI? So what I will say is true for pathology, but is also true for CT scans, MRI, and even, the kind of models that we have for social networks, where, for example, you can be tagged if the software recognizes your face on a photo. So let's say we want to try a model to recognize if an image is from hepatocellular carcinoma or non-tumor liver. So we have a small image, because the first step to develop AI models on histological slides is to cut these very big images into smaller tiles, because an image, a digital slide, is 2 gigabytes, and it's way too large to be processed as is by our current neural networks. So what we do is that we cut these slides in smaller images that are approximately 250 pixels by 250 pixels. And we process these tiles independently. And we can generate, for example, a very high number of tiles. And for example, for a surgical specimen, you can have 300,000 tiles in just one slide. So let's say that for this example, we will take just one of these small image tiles. Then we have these 3 matrices that we obtain. What we will do to train a model is first extract some numerical features from these different matrices. We can extract things that are quite obvious, for example, the mean intensity, but other more subtle features which correspond to the overall texture of the image, the definition, if there are geographic patterns, geometric patterns, circles or lines, and so on. And then when we train, we give also the label. Is it because we know if it's tumor or if it's not tumor? And then comes the most important part. We will send these numerical values and also the label to a neural network. So for the representation here, there are only 3 layers, but there are more in the models that we use. And these values extracted from the image will be processed by these different layers of mathematical computing. And at the end, we will have an output value, which is usually between 0 and 1 because it represents the probability of the slide to belong to the particular label. For example, let's say 1 is a slide of tumor and 0 is non-tumor. So let's say we processed a one image. We know it's tumor. We send the features to the network, and then the output value is 0.8. So in this case, we are pretty happy because 0.8 is close to 1. So it seems that when we give an image to this network, the output value is close to 1. Then we take an image of a non-tumor parenchyma, and we have a 0.3 value. Also, we are quite happy because 0.3 is closer to 0 to non-tumor. So, and then for the third example, we take a tumor tile, and then we have an output value of 0.1. So in this case, we're really not happy because 0.1 is really close to 0. And in this case, the neural network gives a wrong mathematical value because we want this value to be closer to 1. So what is the process of training and what we call backpropagation is that the mathematical layers will modify slightly themselves to modify this value of 0.1 and to bring it closer to 1. Of course, we do not have to modify too much the cases that were correctly classified, but you do that like thousands or millions of times, and in the end, you have a mathematical structure that is fit that when you will give a tumor images, the value will be close to 1, and when you will give a non-tumor parenchyma image, the value will be close to 0. That's the training process of an AI model. So after, when we think of how to apply these kind of technologies to pathology, there are 3 main fields, diagnosis, prognosis, and also biomarker discovery. So diagnosis is a huge field. Though the companies now, you know, they don't want to hurt our feelings, so they say it's diagnostic assistance, but maybe for some task in this, maybe we could be replaced from basic task. So there are huge financial interest into that, and lots of companies are now developing what they call diagnostic assistants. So mainly now for really high volume pathology samples. So unfortunately, and I think liver is part of this field, the fields that are too small now compared to other fields just as prostate cancer, breast cancer, or colorectal cancer, they do not draw a lot of attention from the company. And now the diagnostic assistants that have been developed have mainly been developed for prostate cancer, and it was based on this article, which was one of the first studies that really showed like an equivalent to pathology, human pathologist performance for prostate cancer. And you can have also these kind of heat maps. This is the biopsy core, and you can have these heat maps where it will highlight where the cancer foci are located. And there is also some model for gastric biopsy, again, because it's really high volume pathology samples. So in the liver, there are, to the best of my knowledge, no commercial device that is published, apart maybe from the grading for NASH. But there was this paper in gastroenterology 2 years ago, where they investigated AI to classify the different hepatocellular lesions, low-grade dysplastic nodules, high-grade, early HCC, and then full-blown HCC. And they developed different AI approaches, and they reach a good performance with an area under the curve of 0.93. One of the limits of these approaches is, for example, we do not know if you give an image, for example, of cholangiocarcinoma, we do not know what will be the output, because there was, prior to developing the model, a triage, and these cases were selected first by a human who said this is an hepatocellular lesion. So you can see that these kind of models, they cannot be used as is. You first have to review the slide and say, okay, now I need this kind of model that can identify a low grade from a high grade, or for example, a cholangio from an HCC. So this is the kind of things that are important to take into account. Also, another study on liver biopsy from a French group, and they showed that you can also differentiate HCC from cholangiocarcinoma on small samples that contain very few tissue compared to surgical specimens. For the liver also, we would like to have this kind of model that can diagnose liver tumors, but also whatever liver diseases. But you know that in a liver biopsy, you can have a lot of differential diagnoses compared to, for example, prostate biopsy. Prostate biopsy, you have either non-tumor prostate parenchyma or a prostate cancer. Of course, there are some very rare other diagnoses, but they are really, really very rare. For the liver, it's a little bit more complex. You can have really a wide range of differential diagnoses: autoimmune disease, metabolic disease, alcohol intake, the different viruses. You can have a biliary disease. And it's very complex to develop a model that will be able to recognize all these type of diseases, because they are all defined by subtle features. And that's why I think there also are not this kind of devices available right now. I don't think we will have this kind of model in the near future, but I think what could be useful is to have focused model. For example, if you hesitate between, I don't know, autoimmune hepatitis and let's say steatohepatitis, then have this kind of model that can differentiate two different entities. But it will be very difficult to have a model that will be able to differentiate like more than 50 different diagnoses. For grading, there are a lot of publications, so mainly for NASH, because you know that for most of the trials, the endpoint in NASH is the fibrosis improvement and the histological change that you see before and after treatment. And there was, for example, this paper published this year where they aggregated data from different clinical trials, and they show that AI could reproduce the pathologist grading, and also it's known that AI can identify more subtle changes than the human eye. But after, the main clinical question is, are they minimal changes clinically relevant? Because maybe you can identify that the patient went from 50% of the parenchyma fibrosis to 40%, and maybe this is difficult to say that by the eye, but does it make sense from a clinical point of view? And so that needs to be also prospectively assessed. Also, another type of grading, it's not for the liver. You know that as pathologists, we do a lot of grading on different specimens. And so I speak for myself, but I think for most other pathologists, it's not the thing that we prefer, because it's kind of tedious. And we know that we are not very good, you know, to give a raw percentage of regression, of fibrosis, of necrosis. And this team has developed a model that works on esophageal adenocarcinoma that are previously treated. And they took a surgical specimen of patients that were resected and who had neoadjuvant therapy. They assembled different cohorts, so it's not a lot of patients, but for this kind of samples, it's quite significant. And then they trained a model to recognize the different type of tissue that we may have, for example, tumor, of course, but also the different layers of the esophagus. Also regression tissue, necrosis, ulcerations, if there is a lymph node, if there is Barrett dysplasia, and so on. And in the end, you have a model where you just put the H&E and you have a precise quantification of the different parts of the tissue. And you can say there is 25% necrosis, 31 fibrosis. And I think for this kind of task, really AI has a major role to play, because also we can check the relevance of the prediction. And if the models was completely wrong, with this kind of heat map, we can check and we can decide to take or not take into account the decision of the model. And I think this model, where you can have a visual representation of what happened, is very, very interesting and very also reassuring for pathologists and also clinicians, of course. So I will not go into detail, but briefly, they show that pathologists go faster when they have this kind of tool, and that the prediction of prognosis by the assessment of the pathologist regression or by the assessment of the regression by the AI tool both have clinical significance. So in HCC, we did a study a few years ago. It was on resected samples of hepatocellular carcinomas. So we obtained the glass slides. They were treated by resection in my center, and then we had the digital slides. And what we decided to do is to see if with the slide we could predict a survival of patients after resection. And so we fed the histological slides and the survival status of the patient to our neural network. So you can see briefly that the model was able to identify patients. So they are in the blue curve, which have a low risk of death after surgery, and patients who have a high risk. And what was interesting is that the model stayed significant even when you stratified according to common prognostic features of HCC and also disease stage, vascular invasion, satellite nodules, and AFP serum levels. And this model was further validated in the TCGA dataset, the external dataset. So in this model, which is now quite, I must say, a little bit old, you see that we trained in one center, we validated in another. I think now what would I do if I had to redo this kind of model is to train on heterogeneous data. Maybe I would have mixed patient from my center and the TCGA also and try to validate in another center, because we know that it's very important to have heterogeneity at the stage already.
It's so empty. Yeah, I know. This is the whole week is. I was like, you've been away, right, for a little bit.
So when you introduce some heterogeneity in training, then you have a much more robust model in the end. Now the field of biomarker, which is already, I think, very interesting and blooming, the field of prediction of different set of biomarker with AI. So you know that we do a lot of molecular testing for different cancers. Unfortunately, for HCC, there is no really validated biomarker yet. This is not the case for colorectal cancer. And there is this team from Germany, the team from Jakob Katter, who showed that using digital slides of colorectal cancer or gastric cancer, you can predict the MSI status. And they did a follow-up study in gastroenterology where they were able to gather a very large cohort of, I think, up to 8,000 patients. And they showed that the AUC was 0.96. So it's really impressive. It works on biopsy. And so you may say, okay, 0.96 is very good, but it's not perfect, and you would miss some patient. But what is very interesting with these kind of AI approaches is that you can modify the threshold of prediction according to your needs, if you want a highly sensitive test or highly specific test. And for example, now there is a French-American company which is called Okin, which has marketed a software that is able to identify MSI from the slides. And they do not sell their products saying that they will process every case and make a prediction for every case, but they aim to discard some cases from further biological testing, and they are able in approximately 40% of the cases to predict that the cases will not be MSI with a high level of confidence. And so for these cases, you do not have to do immunohistochemistry or molecular biology. And so you can do some triage and not waste some time and money on molecular biology for some cases. So you can see that I don't think we will be able to predict everything with AI and on genetics, but in some settings you can save some time and you can give an answer more quickly to the oncologist. And if the case is really classified as MSS with a high level of confidence, you don't have to do molecular biology. These models are not really implemented in France because also the business model is not very clear, because it's still quite expensive. I think it's between 20 or 30 euros per prediction. And you know, the immunohistochemistry that we do for MSI is quite cheap. For example, if you include the cost of the antibody of the technician, it's approximately 20 euros. So it's the same cost. So so we prefer to do the gold standard. And also we do not know who will pay for that, because in France, you know, everything will be paid in the end by the state. And I think the national health system is not ready really to put some money in that. And we have to demonstrate that it will really improve patient management, or it will save other type of costs before we can think that we can replace our conventional test with these kind of approaches. So for HCC, as I said, there is no predictive test, but there was this publication who investigated the samples from the trials who led to the approval of atezobev in patients with advanced HCC. And they identify a gene signature that they called ABRS for atezobev response signature. Which the signature include mainly immune-related genes, and they validated also in another series the predictive value of the signature. It was predictive of progression-free survival, unfortunately not overall survival. And but you know that this kind of technologies, so not maybe RNA sequencing, but microarrays have been around for now almost 25 years. Yet, apart from breast cancer, for example, with the gene signature that predict relapse, they are not really widely implemented in clinical practice because it's quite complex. You have to do nucleic acid extraction to perform the biology experiments, then to analyze. It can be difficult, you know, to normalize, and there are lots of problems, I think, that explain that this type of signatures have not been implemented yet. So what we try to do is to see using a conventional H&E that can be obtained in a clinical workflow relatively easily. We could predict this gene signature. So of course, it would have been better to train a model directly on the outcome, for example, response or not, or the progression-free survival. Unfortunately, you know that for HCC, there are some, it's difficult to obtain this kind of sample. There are the non-invasive diagnostic criteria. It's quite changing, and for example, largely in France now, and also in my center, every patient who will have a systemic therapy will have a biopsy. But at the time of the study, it was not the case. So we decided to predict the gene signature. And we trained the model by giving him the slides of the TCGA and also the value of the signature using the RNA sequencing that was available. Then we validated the model in more than 200 patients that were treated in my center, and also in 150 approximately HCC biopsy, because HCC biopsy are the only type of samples that will be available for patients with advanced HCC. And we wanted to know if the model was still valid on biopsy. And finally, we applied the model to a series of 122 patients treated by atezobev in different European, American, and Asian centers to validate if also it predicts progression-free survival really in a real-life setting. So this is the results from the discovery series. So the correlation is very good. Of course, it's the training series, so it's expected. You have the predicted value by the model here, and here is the gold standard, which is the value by RNA sequencing. So this is the best fold of the model during the training set, and this is all the folds in the training set of the model, and you can see you have a very strong correlation. What is nice also with this kind of approach, you can visualize the H&E at low magnification here, and here you can have what we call prediction heat maps, which show you which areas are predicted to really overexpress the gene signature, and there are, for example, in this case, in red. You can go at a higher magnification to this area. On the left, you have some example of tiles that were predicted to have a high ABRS expression. So it was expected, but we showed that there was a lot of immune cells, which are these small blue dots that we see within the tumors. And in areas that were classified as low ABRS value, you have much less immune cells. You have some fibrosis here also. Here it is blood. So it was consistent with the function of the genes that were included in the signature. Then we validated the model, so in the resection sample and the biopsy sample. So as expected, there was a drop in performance yet when you validate usually in an external data set, and also on liver biopsy. However, the correlation was still significant. And then finally, we applied the model to this series of 120 patients treated by atezobev, and we showed that indeed, when a patient has a slide and a tumor slide that is classified as ABRS PI, P is for prediction, the patient will have probably a better, longer progression-free survival. Also, as observed in the paper who identified this signature, we did not find any impact, unfortunately, on overall survival of the patients. You know that AI approaches are widely criticized for their lack of transparency, and we do not know really exactly what happens in a neural network, and it's an active field of research. It's still very challenging to really know what are the image features that trigger a particular prediction. But however, we try to bring some insights by doing spatial transcriptomics using 10x Genomics Vixium kit on formalin samples. This is an example of an H&E slide. Then we apply our model to this sample. You have these heat maps we show you, that show you in red the areas that are considered to overexpress the gene signature. And then you have the ground truth, which is the ABRS signature expression by a spatial transcriptomics. So what you can see is that the areas in red grossly matches the areas in red here. And when we did the statistical test, we indeed showed that the tiles that really are predicted to overexpress the signature indeed show an overexpression of the signature. And you can do that for whatever gene you think is interesting or you want to predict. And for example, these are some genes that were included in the signature. So this was an example of the potential of AI to be used as a biomarker. So next, another last example of the application. I think also we could use AI to do some things that are too challenging for us from a diagnostic perspective. And this is an example of a study that we did in collaboration with Jakob Katter's team in Germany. And you know that combined tumors are patients with combined tumors are very difficult to manage. The diagnosis is difficult. We don't know if we should give treatment similar to that of HCC or the treatment similar to that of cholangiocarcinoma. Given the rarity of the disease and the diagnostic difficulty, I think we will never have any strong evidence-based guidelines. However, the molecular studies of combined cases suggested that a significant percent of combined cases have a similar expression profile to that of HCC or to that of CCA. Also, there are no specific molecular alteration of combined HCC-CCA, and most often they have either the alteration of HCC or the alteration of CCA. So we were thinking that maybe we can reclassify using AI these combined cases as HCC or CCA and test if our prediction make any clinical or biological relevance. So basically it's to reclassify those cases. I do not deny that it exists, this entity. However, it's very challenging, and I think we have to think of other ways to diagnose and manage this patient because, again, given the rarity of the disease, I don't think we'll ever have any evidence-based, high-quality evidence-based treatment for these patients. This is an example of a combined case. This one is really easy to diagnose. You have the hepatocellular carcinoma on the right and the cholangio part on the left with the glands here. However, in clinical practice, in daily practice, I must admit that it's much more difficult than this kind of example I just saw. They are often showed in textbook, but most of the cases we have this kind of tumors where the differentiation is very difficult to assess, or this one, you really don't know what it is, and it's very difficult in this case to say that it's a combined case or even a poorly differentiated CCA or even HCC. So it really poses diagnosis challenges. And so our approach was first to train a model that differentiate HCC from CCA. Very basic model, something very easy to do with the eye. So, you know, when it's easy for the eye, it's easy for AI. And we had a very good performance. We trained a model, and the model was, when you put a slide of a primary liver cancer, able to say if it's HCC or CCA. And then we applied this model to a large cohort of more than 300 combined cases, international cohort. And we reclassified those cases as HCC or CCA. You can see this is an example of a combined tumor. So there are different areas, but in the end, the model will say if it resembles more to an HCC or to an ICCA. And what we show is that when we assess the prognosis of these patients with combined tumors according to this new classification, reclassification, you can see that patients that are reclassified as having HCC have a almost significant better prognosis than patients who are reclassified or whose tumor are reclassified as ICCA. And also after liver transplantation, when the combined case is classified as HCC, the patient has an outcome that is comparable to that of conventional HCC, and this is not the case when the tumor is reclassified as an ICCA. One of the limits, of course, it was the diagnosis of combined cases in this patient was made on the examination of the liver explant, because those cases were those patients were considered to have HCC prior to liver transplantation. Then we investigated also if our prediction matches the molecular alteration. So these are the samples that were reclassified as HCC and samples reclassified as ICCA. And you can see that all these alterations that are much more HCC specific are identified in cases reclassified as HCC. And the alteration also of typical of ICCA are more often observed in case classified as ICCA. So you can see that it's not perfect because we still have some KRAS mutation, IDH1 mutation that are observed in cases reclassified as HCC. Then, as for the ABRS study, what we did also is a spatial transcriptomic to investigate the areas that matter for prediction. And you can see here in red is when the model thinks it's CCA, and you can see that it matches genes that are conventionally overexpressed in biliary cells, epicam, HNF1 beta, or keratin 7. So it doesn't provide a direct explainability, but at least you can check if it's scientifically sound from the biological perspective. So with all that said, you may think that the future for pathologists is that, and this is just an AI model where I ask to draw a cartoon of a pathologist taking a nap while an AI is doing his job. Well, I don't think this will be this way, at least in the near future, but I think this will be very interesting because we will continue from what I think to do our job as we do it now, or select the slides, do the gross examination. For example, this is a colorectal cancer. You review the slide, you assess differentiation, and then you can run different type of models that will allow you to identify more rapidly lymph node metastasis or vascular invasion, even generate some prognostic scores, prediction of molecular subclass, genetic alterations. And in the end, you will have a kind of report who will integrate all that. And these are some fake names, but for example, you run the AI colorist module that will say that the patient has intermediate risk of recurrence, and also some prediction. For example, the MSI is the likelihood to be of the tumor to be MSI is less than 5%, and the likelihood of the RAS mutation to be here is more than 98%. So for RAS mutation, I think it won't work because just just for your information, it's very difficult to predict KRAS mutation in colorectal cancer. So you can see that sometimes AI work very well for MSI. For KRAS, really, a lot of people have tried. It's very, very difficult because I think simply the information is not in the image. So finally, what is the main obstacle to use these kind of tools? So we are very happy to have them and everything, and I think this will mainly depends to end on the regulation. You know, labs in the US, also in Europe, use homebrew test for a very long time, and also, you know that all the immunohistochemistry that we use in a daily practice, none of these tests are CE marked, FDA approved, and a lot of antibodies that we use are made for research use only. But we process these reagents, we use this reagent, and we have some quality tests, quality controls, and we make sure that they are positive when they should be positive, because, for example, we have controlled tissues, and we are responsible for that. So I think there is still room for the use of academic models or non-commercial models, provided they are strictly controlled. And so there are different approaches according, from if you are in the US or in Europe. And for that, because this is not really my field, I asked the advice of Stephen Gilbert, which is an expert in medical device regulation. So it seems, he told me that in the US there is a push for more regulation for AI tests, but also other tests. And I think a lot of department chair are quite also worried, because it's very, very complex to have like 150 immunohistochemical tests to be CE marked, FDA approved, very costly, and it will take a lot of work. And in the EU, he told me it seemed that they will leave some room for homebrew tests, and this will be our responsibility to use the kind of AI models. We will have to know their limitation, how they behave in our environment. And of course, for example, if you have an AI model that is fit to detect Helicobacter pylori on gastric biopsy, we will have to make sure that indeed the model works well in our environment. So we still have to define with the quality insurance societies what is needed to really assess the performance of a model. So, but I think it's something really important, and that will really determine how much AI we will be able to use in our daily practice. So with that, I would like to thank you all for your attention, and also thank all the group and all the people that were involved in the different work that we presented, and also warmly thank Xindre Zeng, which was a PhD student and now in a postdoc, but did a lot of work, a lot of the work that I presented here. And I will be happy to take any question. Thank you.
Thank you. That was very interesting. Actually, I really did a lot of aspects. You know, before we go, I'm sure there's going to be a lot of questions. What I never realized, you know, to me this looks like a little bit like the pathologist used to get a section, and then he chooses, you know, I need this extra stain to do immunohistochemistry for this marker or this marker. The way you propose this is, you know, you get your H&E, and then you just choose this test or this AI test, which I think is a very interesting concept.
Yeah, because I think that also all the immunohistochemistry that we use in daily practice, for example, CDX2 that we use for colorectal cancer, when we have, for example, liver biopsy of an adenocarcinoma, we do this test to say, okay, it's probably from the cancer from the large bowel. These tests also are not CE marked, FDA approved. They have some limitation. We know this limitation, and it's just one more, you know, one more information that we integrate, and also a kind of model like that. We will know that the model is not 100% sensitive and specific, yet it will be taken into account in the final decision. So that's the way I see this.
All right, so I see Shin has a question.
Oh, thank you, Julian. This is really fantastic. And I remember I met with you a couple of years ago, your presentation. This is really moving forward, so exciting. And like, you know, the field I can see that is really interesting. So obviously that we have a wonderful leaders in our own CCI, actually also in a leader in the AI and doing those. I want to actually ask him more generic questions and see how, I mean, you have, you know, think about this for a long time, see what you think. we understand that you quoted the study from the Chinese about 8,000 image, and then there's a possible overfitting. That's difficult to identify different cancer type. This is embedded into the issues that I have been actually follow. I've been follow Jeffrey Hinton and Fei Fei Li, the discussions, and they're in the ImageNet, how do they creating. One of the things that come from discussion is that current methods is able to predict accurately for whatever the imaging is, only when you have enough data. So in other words, the initial data sets created imaging by Jeffrey Hinton's lab is about 60,000 image. They couldn't improve until ImageNet created with 14 million image. And then the AI is sufficiently able to, no problem. This is what you see the grocery store that you can do that. So my question is, what do you see? Because in terms of pathology, how many you think that we could actually create it in curing? How you move forward this field? Sorry about that very vague question, but
no. So it's a very important question. So it's true that when we use our models, so even before this new what we call the foundation models, we use pre-trained models. First, when we started, we used models trained to recognize cats from dogs because there was the only one available. And now there are some foundation models, and many. There every week a new foundation model, and these kind of models are very important because they are trained without a label. Basically, what happens when you want to create a foundation model, you give a model thousands and thousands, millions, billions if you have slides or images, and it will not learn to predict something. It will learn all the types of patterns that you can have in an image. And for example, the models I think you mentioned will be able to detect all the patterns that you can have in a histological image. So when you will then want to, what we do to predict something in particular, you will already have a model pre-trained that is fit to recognize all type of architecture, lines, or whatever pattern you have in an image. And so you need much less data to predict something. And for example, now we are working using the kind of models that you mentioned, using foundation models. Even we try to do some basic model to recognize liver cancer from non-tumor. Even with 50 cases, you have very impressive performance because the model is already able to identify whatever patterns. Then you will have to tell them, okay, this pattern is HCC, this pattern is non-tumor. But it will really allow to speed up the development of the model. And I think also people often ask, how many patients do we need to make a good model? Of course, if you have 10, 20, will be difficult. But if you have high quality data, and depending on the outcome also that you want to predict, if, for example, it's balanced, like it's an outcome where 50% of the patient recur and 50% do not recur, even if you have like 100, a data set of 100 patients, if you have good quality, you could obtain interesting results. Maybe if you want then to apply it in clinical practice, you will have to add, but yet this kind of foundation model really allow you to not collect thousands and thousands of cases.
Just to be I guess the extension is to see whether most of the model we were trained and we're doing right now always retrospective. There's no study actually prospectively. So in other words, to test whether this is indeed useful, we actually have to define something, do prospectively.
Yeah, so it's a very important question if we talk about the clinical application. So the main obstacle for that was the lack of digitalization in lab, because if you want to run something prospective, you will have to ask your colleagues, okay, you take the slides, you send the slides to me, then I scan it, then I predict and everything. Very complex. And now that more and more labs are digitized, it became relatively more easy. For example, my department, we are fully digitized since approximately 1 month. And we have other colleagues also that are digitized. So we plan to launch our first prospective study, I think in February, with where basically what will be needed is just a right click on the mouse on the slides that you have in your daily practice, and then you send the slide to a folder, and automatically you have a prediction. And I agree, this is completely mandatory to assess the model, but the issues now were the obstacles were mainly technical so far.
Thank you.
Are there any other questions?
Can I ask a question?
Li Shun, yes, sure. And then I believe Aitan also just unmuted himself.
Yes, yeah, very interesting talk. And people start talking about the concept of digital twins based on genomics data. But genomics data, they are not accessible for most of the patients. But H&E image actually, for most of the patients, you have H&E images. Do you think it's possible to, based on digital twins, to kind of build those digital twins based on the H&E images and to do different kinds of tests?
So, so I would say for the digital twin, which is also a very active field, I think yet we still don't know really how these digital twins will reflect the human organs and everything. I do not have personal experience, but I'm quite doubtful that we will really be able to model everything, because you know, and you think you know also better than me, that when you do an experiment, if it will go wrong, sometimes you have no idea of what it went wrong, and you have a completely opposite result and everything. So you know, in biology, you change just such one small parameter that you don't even think of, and it changed the outcome. But I know there are teams that are trying to, for example, in the liver, they have done like 3D pathology to have the full architecture. Then you do 3D spatial transcriptomics, which has cost a lot of money because you have to do every slide. And they try to reconstruct like a lobule and what happens in a lobule. So of course, I think if you want to do a digital twin, you will have to add up these different types of modalities. But I think this is interesting, but I think yet there is a lot of work ongoing. And I think I did not check the literature very recently, but I think we still don't know how good we will be able to predict the behavior of an outcome of a whole organ or of a whole system.
Aitan?
Yeah, Julien, I just wanted to say a really fantastic work, and it's so much fun to see how the field is developing and how your own work has been developed. It's extremely interesting, I think. To me, personally, it's the most exciting development. What's happening now in AI is the most exciting developments that I've seen in my career. And you know, I'm working in precision oncology for 15 years. It's a truly transformative game changer. Just to tell the audience a small personal perspective, I was a computational neuroscientist mainly before I came to cancer. Julien, I'm an MD, PhD, and I did my residency in psychiatry. I know nothing about cancer, actually. And I actually was fortunate to work with people like Jeff Hinton and John Hopfield, I don't know, 20, 25 years ago. And I just left the field because I thought it's not going anywhere. And I said, okay, we will not be able to understand this. This is not going, you know, backpropagation was stuck for 15 years or whatever until Hinton came with deep learning, all that. I didn't see that. And I said to myself, I'll go and work on an easy problem. I'll just try to understand cancer, right? That's whatever. And I was wrong big time, as always. And I think it's now so exciting, and the pace that things develop is extraordinary. Shin rightfully asked, well, what will be Is Hinton right that the machines will conquer us, or Jan LeCun, who says it will be for the greater good, right? I have no idea. Profit is given to the stupid. But I think that the main, and that's what really troubles me, the main hurdles for incorporating all these great AI in the clinic is not their ability to do stuff. I mean, you know, we and others have shown that they actually perform better than expert pathologists in specific indications already. It's the regulatory, the conservatism of the system, crazy, stupid, unbelievable stuff that the slides are not digitized. I mean, people will look in 10, 20 years and they look back and say, how could it have been? All these people are so stupid, seriously? You know, we should keep... Okay, so I'll ask the audience one question and then, Tim, I promise to shut up. What is the annual cost of treating a cancer patient in the US today? Just tell me this number. Anyone? Dr. Gretton?
Aiton, we have 2 more questions. Why do you give us the number so I can have the other people also ask the questions?
$150,000 to $200,000 a year. That's the cost. The cost of digitizing, doing screens, RNA, single cell, just to get better matching treatment is $10K, $20K. How come we are not spending it? To me, seriously, it's a crime against humanity. Okay? That's my view. And I'll shut up.
All right, so I think Jungmin Lee has a question, and then Mark is next.
So thank you, Ethan, for your preaching. By the way, Julien, excellent presentation, and that's very insightful. So I'm a medical oncologist with expertise in ovarian cancer. So my quick question is, especially in the setting of ovarian cancer, which is one of the rare disease, so we also have some challenges for digital pathology and AI-based approach because of low sample size. Unlike breast or colorectal cancers, ovarian cancer is a rare disease. We don't have many data sets to begin with. So, you know, since you also bring up this as a, liver cancer as a rare disease, whether do you have any insight or recommendation, especially for the rare cancer type? And also my second question for your insight and advice, especially the disease, ovarian cancer has a very different behavior, whether they have metastasis in the peritoneum versus metastasis to the liver. So if we get the biopsy from the liver, it may have a very different, animal compared to the disease in the metastasis, peritoneal disease. So sometimes I see many mixed response in response to the certain target therapies, the disease in the liver gets smaller and the disease in the peritoneum get bigger. So how this kind of AI-based pathology approach can address this challenge when disease response is not that straightforward. So thank you so much for sharing any insight.
Thank you. So for the first question, so it's true that rare diseases are quite a challenge, and also I would like to mention the importance of academic models, because I think very rare diseases will never interest any company, and they will be completely left behind any of the developments, because I think the companies will not put a lot of money in developing a model that will only be applied on a very, very few patients. So of course, unfortunately, it's almost always true. The more data you have, the better the model will be. But I think for this kind of ovarian cancer, and I think there has been publication, for example, for a prediction of HRD or other alteration, I think you can also try to have this kind of models, as I discussed, where you use a pre-trained foundation model and then you apply it to a smaller cohort. Of course, it has to be at least 100, 200 patients. But I think even with 200 patients, you could have interesting results. And I think also we have to consider for the field of prognosis prediction, biomarker prediction, we don't have to be perfect because the staging systems that we use, TNM, whatever histological grading, Furman in the kidney or whatever, they are far from perfect. I think we estimate just classes of risk. And if you have an AI model that just adds some information to this system, it's still very interesting. And so that was for the first question. And for the second question, sorry, I do not. I got lost. I don't remember the second question. It was
the different sides of the metastasis and outcome.
yeah, sorry. Yes. So for that, I think I'm not sure AI will be able to reply to this question, but I think also if you the better if you want to develop a model is to focus in one really particular situation with a particular question. Like I think also if you have a model sometime with peritoneum biopsy, or if liver biopsy, you will have some noise due to the adjacent liver or to some things. So I think from a clinical point of view, the best is to focus in a very one particular situation, a clinical problem, clinical issue that can solve in this case. In the liver, apart from cancer, it's quite rare, for example. But for example, there is one situation, it's alcoholic hepatitis. I think patients with this disease are not biopsied in the US, but in Europe, they have this use of biopsy every patient. And what is interesting, if you want to develop kind of biomarkers, is you have a biopsy at D0 before starting corticosteroid therapy, and the biopsy is systematic. So it's always the liver, always day 0 before corticosteroid therapy, and then you have the treatment and the response or not. So I think this is a good situation. And for example, for ovarian cancer, if you want to predict response, and if you have different response according to the ovary of the peritoneum, I think probably you will have to biopsy both sides. But I understand it could be complex.
Okay, and the last question actually now goes to hepatology. So Mark.
Yeah, thanks, Tim. So, Julien, that was a wonderful talk. I'm a hepatologist, not an oncologist, and I'm sort of just trying to get into the field. And pardon me if this is a naive question, but so the H&E slides can really only give you information about grading. But if you want to get additional information about staging, and I study viral hepatitis, so if you want to look at the actual location of the virus in the liver, you can do immunostaining. So is it possible with these models to develop a unified model using data from 3 different sources? So from a H&E, a trichrome, and say an immunostain, and put a composite model together.
Yeah, it's completely doable. That's what also we are trying to do. You can feed the model with the H&E, which has a lot of information, but also, of course, you can feed the model with the CD3 staining or whatever staining you have additionally, and you can. So there are different approaches to do that. You can do what we call an early fusion approach, where you mix all the data before and then you train the model. This could be interesting. Unfortunately, we know that some networks are more fit for kind of data than the other. You can even put a scan if you want. And yes, I think which is a more practical for application to the clinics is the late fusion, where you took every modality, you make a prediction, then you apply some weights on the prediction, and then you have a final prediction. So also if a data modality is missing, it's okay. You will have a less accurate prediction, but you can still have some prediction. If you mix everything at the beginning, you have to have all the data for all the patients because you cannot have any missing data. But definitely you can train on trichrome stain or immunohistochemistry. And there, for example, there was a paper. I know if you know what the immunoscore, for colorectal cancer, which was developed to predict outcome in patients with colorectal cancer, like looking at the CD3 and stainings. So there was a company and everything, and now recently there was a Nature Medicine paper where they showed that you can do a immunoscore by AI. So you just put the H&E, you put the immunohistochemistry, and you have the prediction. You don't have to do the, like it was a little bit old school, the way they identify the cells before, because they did image analysis, but it was supervised. Like there was really a model trained to recognize the size of the cells and everything. So it was very heavy. And now you can just feed the CD3 staining and you have the same accuracy.
Okay, Julien, thank you.
Thank
That again, that was very, very interesting. You can see there was like questions from all over. So, a lot of interest by, many disciplines beyond liver cancer. And I just want to thank you again. This was an excellent talk, very provocative. And thank you everybody for a very lively discussion.
Thank you very much.
Bye-bye.
Bye.